Hello, everybody. Good afternoon and welcome. Thank you for making time for our third virtual Health Equity Leadership Institute, or HELI, event. Promising practices for campuses to support community-engaged health equity research, a call to action. We really fit in a lot of words there. I am Sarah Esmond with the University of Wisconsin Collaborative Center for Health Equity, also known as UW-CCHE, and I'm honored to moderate today's program. If you're new to HELI or to CCHE, our events are designed to be useful for both academics and non-academic audience members who work or who wonder about working in partnership to address health equity. Our format moves quickly. We want to honor your time. We appreciate that you vote with your feet to attend things like this. We do record our offerings so that we can make them available to those who cannot be here. And we rely heavily on the chat to highlight resources and individuals who we mention and that we mention, so you can explore those more at your convenience in case they're not familiar to you. By way of introduction, and I think you'll see in the link in the chat a link for the little more information. I've served as the UW Center's Administrative Director since 2002 and have acquired a lot of knowledge about researchers, NIH Research Awards and training grants, how higher education research infrastructure and culture tends to operate and why that is. I've also established, led, supported, and published on community academic partnerships and led the implementation of 2 Center of Excellence awards from the NIH, and more recently had the great opportunity to lend administrative leadership to our 3rd CTSA award here, our Clinical and Translational Science Award here at UW. So why are we hosting today's program with this topic in mind? Because many of us in health equity research recognize the very important role that research administrators play and how that directly impacts the effective setup and facilitation of community academic partnerships and also of health equity research activities. I'm going to ask for slide 1 to come up just to give a little orientation to the audience of how we think about health equity in CCHE. We really recognize that it requires a variety of efforts from each of us in academia and other settings. We call on colleagues across the board, both on and off campus, to lend to our health equity work. Our first 2 HELI programs introduced community academic research partnerships, and we highlighted some of the individuals that made that work go. Today's program is going to pivot to examine the structures, practices, and policies that influence, inform, and support these partnerships for research, but also more broadly. So we're going to use some NIH Scholar awardee data, National Institutes of Health, Scholar awardee data, and a HELI Scholar scientific autobiography to consider what might explain some of the trends, which are troublesome. We'll discuss innovative scholarship on fiscal readiness and administrative processes in higher education that's informing some uniform guidance and culture change to sustain, more equitably sustain community academic research partnerships. I'll also share some examples here from here at UW that are aligned with some of the movement we're talking about today. But today's program really serves as a call to action for each of us, academic and non-academic audience members, and specific actions we can take to ensure health equity scholarship and health equity scholars succeed in their efforts to eradicate disparities in health and health outcomes. Importantly, before we go too far, I want to take a moment to acknowledge that while we gather virtually today, our campus resides on the original homelands of the Ho-Chunk Nation, or Dejope, in Madison, Wisconsin. As we promote engaged research partnerships, we stay mindful of the land we use and acknowledge that land stolen or put into treaty form has negatively impacted tribal nations in Wisconsin and elsewhere. Understanding and learning from these histories, listening to those sharing stories of these lands that we call home, is essential to working with integrity and honoring partnerships with neighbors. Thank you in sharing for a moment of that land acknowledgement. I have a few other acknowledgements and housekeeping bits before we proceed. HELI is supported by the University of Wisconsin School of Medicine and Public Health, the UW Institute for Clinical and Translational Research, and also the Wisconsin Partnership Program. And I'm sure my team is putting into the chat several links in case those are not familiar entities to you, but all have ongoing commitments to health equity scholarship, community academic research partnerships, and community engagement excellence. So thank you to them. Thank you also to our presenters today for their time to prepare and be with us today. Please, you're encouraged to use the chat for any questions or comments or insights you want to share. We're going to use those and try to incorporate them live as we go along, but we'll also have some time before we part ways to tackle as many more as we can. Next slide, please. Let me do some introductions of our colleagues today. Tisha Felder is a return superstar to us. She's a HELI alum, colleague, and friend, a tenured associate professor at the University of South Carolina College of Nursing. She's instructed at HELI numerous times in addition to being an alum herself, and will share more about her health equity research journey in her presentation, using research challenges as a catalyst for change, strategies to support community-engaged health equity research. And then next, I'd like to introduce a new colleague to me, Dr. Lori Carter-Edwards, who's joining us from the Bernard J. Tyson School of Medicine, Kaiser Permanente in Los Angeles. Welcome, Dr. Carter. I didn't realize, and she let me know a little bit of the fascinating history of the naming of that School of Medicine and Public Health for Mr. Tyson, who was a healthcare influencer before that term became so popular. Former executive and CEO at Kaiser Permanente with a long history in healthcare and a commitment to service and health equity. So we're delighted to have you here, Lori. Thank you for coming. As a little bit of opportunity to introduce you, I prepared a couple of questions so our audience can get to know you a little better. So join me on the screen. Thank you. Welcome.
Well, thank you.
Your first question is, how would you define your current research interests or experience, and why is it framed in that manner?
This is a great question, and thank you all for having me here with this very important initiative. And Sarah, just thanks for the relationship you and I have built in this very brief time. Based on my training, I'm a cardiovascular social epidemiologist and health educator. But now I would say I'm a community engagement, translational science researcher and practitioner. And the practitioner part involves the work that I do in terms of capacity building within communities, but it also includes the practice of administration and working within our institutions to remove some of the barriers that prohibit the smooth operations of community academic research. And so I frame my profession and what I do in that manner, because we're now in a space where if we're going to address health equity, it's factors such as these that we need to be building our expertise in. So community engagement, the ability to translate and communicate, and the ability to practice what we preach are all elements that help get us closer to health equity.
I think for the administrator and me and the project manager and me, those are things that are in my immediate control to do something about, which feels comforting in some ways relative to so many other things. So thank you for articulating that so clearly.
Thank you.
When you reflect back on your academic and career trajectory, what event, decision, or experience was so critical that if it had not happened, you would not be where you are today? Just something light for you to chew on.
Heavy question, and the response is always something usually people think it's one event. It's usually the culmination of things, and something tipped the scale to say enough. I left doing a lot of the work that I did in cardiovascular epidemiology to pursue the work that I like to do in the community. But when it hit to try to become an administrator and really work on community engagement was when I was an administrator within a center. And I was the principal investigator for one of the core projects in the center. And we had a community partner who was responsible for providing the funds to the community partners that were helping to do the work on the ground in another part of the state, in a rural part of the state that we were further away, probably about 2 hours away.
Right.
So the work required our community partners to be heavily involved. When there were issues regarding funding, because usually communities, they're riding on the funds that they receive. They don't have a resource or a reserve to work with. And if something is written incorrectly on a form that goes to the institution, which requires maybe 6 signatures before they can get paid, that delay can cause further delays. And we had a partner who was already in a financial, how should I say it, had issues that they were trying to address. So when this happened, it made it difficult for this person to then pay the people who are doing the research on the ground, therefore halting the ability to do the work, therefore directly impacting the science. And at that point, that was in 2012, 2013, that's when I realized it was time for us to try to work with people in the institution to say, how can we change this? So I brought together the head of the Office of Sponsored Research, other researchers, other people running centers and community partners together. And that led to the Fiscal Readiness Initiative back then. And now you now know about it. And we now have a paper finally published on it. And it was not a sexy topic. So when we first tried to submit a grant with Yale, Medical University of South Carolina, and Vanderbilt and UNC, it's not sexy. It's an agnostic topic, and it's administrative. So how do you tie that to a disease outcome? It's very difficult. So we weren't getting anything published. I mean, we couldn't get the grants. So we decided, okay, let's do the science. And that's the paper that's been recently published in April in preventive medicine, in academic medicine. And now people are actually targeting that and saying, thank you. Someone's actually published this. But most people don't want to work in this space. It's very difficult to do this, but I'm committed. And that was the turning point back when that happened with the one community partner. And I couldn't help him in that space. And how could we change the system a little bit to make it better for him and others across the country?
Thank you. Thank you so much. A scenario that is familiar to me in terms of many of the elements and the wake it can leave, both in terms of the partnered work that the individual has brokered to create the space to do the partnered work, but also the institutional reputation and credibility backing that work, the sponsor, everybody's impacted. Thank you so much. Yes, you referenced your April publication, which I'm sure Caitlin will provide a link to in the chat. This was instrumental for me to see something published in this area because, as you so rightly put, we're just not sexy enough in research administration. And I immediately shared it out to our Health Equity Leadership Institute scholars, and that's where Dr. Felder and I kind of had a little intersection about how to talk about this in regards to her work. So next, I want to turn the mic over to her for a presentation. Dr. Felder, are you ready for us?
Yes, yes, I am.
There she is. We will get your slides loaded for you here.
All right. So thank you so much, Sarah. And again, I just want to say thank you for the invitation to share this virtual space with you and Lori today. And I will say, in preparation for this presentation to kind of set the stage for our follow-up conversation, Sarah and Lori, I think their perspective really pushed me to think beyond myself as an individual. I think as health equity researchers, we tend to get used to doing a lot on our own, and especially for those of us who may be first-gen faculty, first-gen college grads. And so I think this really helped stretch me as well to think beyond the things maybe that I could do, but also things that could be done in infrastructure to better support myself and other scholars that may be joining us today who are interested in this work. So to set the stage for our follow-up discussion, I'm going to start by talking about national trends in attaining R01 status. I'm going to share a little bit of a case study about some barriers and facilitators that I've had myself as a K awardee. And then I'm just going to summarize this by providing some suggested actions to enhance community engaged health equity work across different players, and of which many of you participants also reflect. So while there are many markers of research success, we know that in academic institutions, the R01 is like the holy grail. It is the gold standard. Many times it's necessary to attain tenure in many institutions. So it is something that many scholars are kind of groomed to achieve. And it's the oldest grant mechanism offered through the NIH. And we know that NIH is one of the, if the largest funder of biomedical research in the world. So R01s are a big deal within the academic space. And on the pathway to the R01, NIH provides a long list of different training grants and fellowships to support that transition and prepare you for the R01. So one of those mechanisms are the Career Development Awards, or what we tend to call K Awards. And these awards will give you the support to do extensive research, professional development training, but also to do some really focused research that would help you to create that preliminary data that you're going to need to attain the R01. And unfortunately, like many other sectors, we see a lack of racial and ethnic representation among those who achieve R01 status. And so if you look here, particularly among Hispanic or Latinos and Black and African Americans, you can see relative to our representation in the country, we have very small rates of attaining R01 status at NIH. And so here, I'm just going to walk through just a couple slides of this data. So this data is focused analysis that was done at NIH, where they were looking at T32 postdocs. And so if you're not familiar with that, there's tons of alphabet soup at NIH, but the T32 is a postdoctoral mechanism. And so all of these outcomes are among those who already were part of this training pipeline. And so even among those who were in that training pipeline, unfortunately, underrepresented minority women had the slowest rates of attainment of the R01 compared to all these other groups. And so that's, and again, that's very troubling given that all of these applicants are kind of coming from this pool of people who've already received a very high level of training. And here, the analysis is zoomed in more for those who had K awards. And again, the K award, one of the intentions of the K award is to kind of help springboard investigators to R01 status, but very similar to the previous data, underrepresented minority K awardees attain R01s at a much slower rate than non-URM colleagues. And many of you, if you follow this work and see everything that's been going on at NIH, there's been a paper that came out that was really demonstrating about 20% of the difference in Black and African-American scientists achieving R01s is accounted for by topic choice. And when you look closely at this, all these different words within these word clouds, you see things like intervention, patient, disparity, all of those kinds of words. Those are the topics that many of these scientists are really focusing on. And when you think about it, those are the same topics that relate to community engagement and health equity work. So unfortunately, based on this analysis, it was found that topics in these areas receive much lower scores and subsequently are less likely to be funded. So why does this even matter? So because certain topics and certain investigators face systemic barriers to R01 funding, we within the academic and non-academic sectors must invest more support for investigators who are committed to this work. And these are just a couple of things I was thinking through about, like, why does this even matter? But when you think about the R01, for example, much of that work, the results that come from those R01s is often translated into changes in clinical care, even interpretations for health policy. And so they could have a tremendous amount of impact in the world. And how are we going to achieve health equity if we don't have investigators who are committed to this work getting these type of grants? Also, these grants are investigator driven. They drive the questions. It's really important to have people committed to this work who are driving important questions that may be overlooked or not even thought about by people who are not necessarily focused on addressing health equity issues. And lastly, and again, kind of a frame for this entire conversation today, is that many of these barriers are very systemic. So while, yes, I think applaud NIH for the efforts that they're doing around addressing structural racism and peer review and all other aspects of the infrastructure of NIH, it's imperative that even outside of NIH, that institutions, academic and non-academic, again, we all look at ourselves and see what is it that we're doing or we could do, policies and procedures that could be changed that could enhance the contributions that health equity and community engaged investigators could make. So now I'm going to kind of shift a little bit to using more of like I would say a case study of the work that I'm doing as a K awardee. So my work is focused on improving adherence to hormone therapy among disadvantaged breast cancer survivors. And that's really operationalized in terms of women who are insured by Medicaid. So according to the data, women who are insured with Medicaid have lower rates of adherence, higher rates of mortality. For anybody who does health equity work, these patterns are consistent across disease states, so it's not a surprise to you. And so in this, I'm finishing up my K. This is actually my last year, but my first aim was really to explore kind of these multifactorial factors that influence adherence to hormone therapy. And then I will be using that information to inform the development and evaluation of a multi-level intervention. So for the first aim, I did two different things, again, because I'm trying to approach this from a multi-level standpoint. I wanted to talk with not just breast cancer survivors about their experience, but I also wanted to talk to providers. We're very aware that sometimes provider bias plays a role in the information that patients receive, and sometimes it can impact that relationship that the patient has. And so I wanted to kind of get both of their perspectives about what are some of the factors that actually impact a patient's continual decision to adhere to hormone therapy. And so I won't go into the weeds about the approach and all that, but we basically did qualitative interviews with two separate groups, and the recruitment process was very different for both. And most of the challenges that I faced were actually around the healthcare professional recruitment, which I'll talk a little bit more about. So what didn't work well? So most of the barriers were between financial and more these institutional or administrative. So of course, with the K, your time as an investigator is bought out about 75%. So you have a lot of opportunity to really focus on your research. However, the research budgets are pretty limited. And in my process of applying, I had to make changes to my K because I was funded kind of in between funding periods. And I had to address some reviewer comments. And there was a reviewer who felt adamantly that I did not need a graduate research assistant as part of my K. And so I ended up having to take that out. And at the time, didn't really think about negotiating that. And so what ended up happening is that I, as a PI, was doing everything. And of course, for the most part, for Ks, that's pretty similar. But it was very challenging when facing additional barriers to be the sole person who's recruiting, screening, and doing the data collection. In terms of the administrative or these higher level barriers, I am at an institution that is not an academic medical center. So most of the time when we're looking to have relationships, we have to establish some of those. So we have clinical partners, we have community partners. And again, because of the work and the focus that I'm in, sometimes those formal partnerships are not there, and it's kind of starting from scratch. Even things like policies and procedures for getting cash advances, they don't always work with recruitment. So that was another challenge that I had at a very important time when I needed to have access to being able to pay the participants. And the biggest barrier I had was really around IRB and site approvals, which is something I never would have anticipated. So what was going on was I was interested in interviewing healthcare providers, but I was sending an email invitation letter to people through a variety of different professional organizations, contacts. And what was happening was every time somebody would reach out and say they were interested, I would go back to them to find out who I needed to contact to just make sure that it was okay to interview them on campus or wherever, offsite or whatever. And I got very different responses, from people saying, oh yeah, you can come and interview me during lunch, to some other cancer center that I was trying to work with made me go through an IRB application to apply just to share my email invitation letter with their people, only for me to do all that and for them to say, we're sorry, we're not interested in supporting the study at this time. So in my mind, I think some of the barriers were really around their concern about what people might share about what was going on maybe in their healthcare institutions. I don't know, but it did cause tremendous delays. So one of the things one of my mentors suggested was to document in this entire process of trying to recruit healthcare providers. And I'm really glad that she did, because I ended up being able to analyze all the email and phone communications I've had to really see how much of an impact this has made. And so I just want to point out here that it took as long as 150 days to get some sites to basically come on board. So that is about 5 months. And that was before doing any interviews. And then one of the other kind of stretches, it took 233 days to be able to recruit one particular type of healthcare provider. So if people have any questions, I'm happy to talk more in detail, but I'm just showing this as just so you can see that sometimes some of these delays that don't have anything to do with you or your work or your interests can impact your ability to collect your own data. What did work well? So engaging professional organizations and peer healthcare providers. So most of the time when someone would tell me they were interested in participating, they would then kind of champion it within their institution and see if there were others who were interested. And I really appreciated that, because it was really kind of like snowball recruitment really helped. Being flexible and responsive to the participants and partner schedules. Of course, working with healthcare providers, things happen with patients all the time. So I had a bit of rescheduling, had some people I was just never able to interview because of their busy schedules. Also communication styles. In academia, email is king. Outside of academia, that is not always the case. So even things like making sure I'm making phone calls versus doing email, and things that we kind of take for granted because that's the way we do business, but that's not always the case with non-academic partners. And then finally, the formal partnerships, once they were established, they were really integral to my HCP recruitment. So here again, just emphasizing this area that I circled. So one of the sites, someone contacted me, said they were interested, and they forwarded it to their supervisor, who then said, hey, our whole group is interested. They had lots of different healthcare providers. So that was my goal, was I wanted to get a variety of people, from nurse practitioners to social workers to navigators, nurses. And I was able to interview a lot of people at that site, and they provided space for me to do it there. Now I did have to get IRB approval to work with them, but for me, it was a win-win situation. They really helped facilitate this process. And this was the site that took 150 days to get that approval, but it ended up yielding the largest number of participants with an extreme diversity of those participants. So this was a place that it actually accelerated my recruitment tremendously. So having said all that, I just want to kind of pull this all together and just suggest some actions that we as scholars can do, all those that may be with us today who are clinical and community partners, maybe some things that our partners can do, and then also our academic institutions. So I feel like as scholars, we always have to be prepared to negotiate. I think that's something that we should all do, especially when you're working on grant submissions and you get grants funded. So looking at negotiating alternative sources of funds, leveraging professional networks, those things work very well for helping you to establish and find really good clinical and community partnerships. I would say within the clinical and community partners, please lift up and reward your champions. There are people in your organization who are the ones who broker that relationship between the researchers and teams and these academic institutions, and they should be rewarded for that. And then here, I try my best to explain this because, like I said, this whole issue around IRB was very weird to me. But just kind of figuring out amongst these clinical sites, how is it, and in what ways can clinical staff participate in research? What is the kind of consistent message? I got multiple messages from the same institution from different people at different times. And even when I asked somebody to go on record to say something, they told me they weren't able to do that. So it was a very weird kind of process. So I feel like that's a unique place for maybe academic medical centers to kind of clarify how that works for their staff to participate as research participants. And I really think it's important for us moving forward, because so much work is focused on, a lot more work is using these multi-level approaches and implementation science, all these things where working with clinical partners and working specifically with them as research participants is important. And last but not least, academic institutions aligning grant incentive programs to award PIs. It will help with them having discretionary funds, but also with retention, working with HR to establish very unique staff positions that can accommodate part-time roles when the budgets aren't really plentiful, but also funding transitions so that those staff still continue to have a role and a presence at your institution. And lastly, prioritizing how administrative and fiscal operations facilitate community engaged health equity work. And with that, I will stop and welcome questions, and also looking forward to our dialogue.
Thank you so much. That was a whirlwind. You did a beautiful job laying things out. Thank you so much, Dr. Felder. I will invite Lori to join us in some conversation about your presentation, because I'm sure she has some thoughts with regards to some of the ways she's positioning her work and with colleagues. You so nicely illustrate why the health equity research itself just requires some unique contributions from so many spaces. And I think I'm appreciating very much the things you ran into both prior to the award landing and preparation, but then also actually trying to implement. So much focus sometimes is on the acquisition of the grant, yes, and not enough attention on sort of preparation ahead of time, how yes, you can get help and support with that, and then of course implementation. So I'm thinking about audience members who may be wondering, if I haven't done a research partnership before, and I just heard this presentation by Dr. Felder that kind of sounded wild. How would I step into a research partnership? Where would I start in terms of inquiring about opportunities to be in a partnered role? If I'm thinking about that, have done it before, haven't done it before, do you have thoughts for me? And Lori, you're welcome to join in anytime. So just wanted to put that forward to you, Dr. Felder, to respond to first, given the experience that you just laid out in your K award case.
I feel like I can answer that mainly from the perspective of, again, being at a university that is not a part of an academic medical center, because I think that partnerships with those type of institutions are different and the process is probably different. So I feel like for us, the bridges in many cases may not exist at all. And so I think if people are interested, they just need to go with it and initiate it. And so because so much of what we do in these academic institutions is publicly available, you can look up profiles of people. I know on our website, At University of South Carolina, they have faculty profiles that tell you what people do. You can just search for certain terms and things will come up. I would also say, reaching out to, again, really just having to find the information, but finding the information for offices of research in certain, so pretty much every department has their own office of research. And those people could certainly tell you who are good partners, potential partners to work with. But I definitely say in our setting, it's a lot of cold calling. I know even the work that I've done with the partners that others had not already established those relationships. I just emailed them, I just called them, and you just hope for the best. So so a lot of it is just kind of putting yourself out there. But I think when you connect with somebody who's already articulated their passion for health equity, community engaged work, your answer is probably going to be yes.
Thank you. Thank you. Yeah, I think sometimes it takes cold call, just as we as those on campus reach out and have to do repeat cold calls and inquiries. And there's risk inherent in that because people can just not return your call, believe it or not, or just say no, they're not interested. I think agencies and entities off campus, similarly, it can take a couple of tries. It does take some risk to kind of put yourself out there, but I've had the pleasure of facilitating so many community organizations. We have a very large campus, it's very diffuse. And I think if you can get into that, that highway of exchange, you can very quickly get some navigation help and some support to find people. Thank you for that. Lori, did you have anything that you wanted to add on that?
Sure, there are a couple of things, and I have something that's also in queue. Tisha, that was wonderful. It's a great thing that you went through some of those experiences, and it's unfortunate in some of the others. First, let me say, you're not alone, all of you who are on this call, whether you're a community partner, whether you're a staff member, whether you're a faculty member, you're not alone in this process, and it involves all of us to do this work. Secondly, the kinds of support that you receive by attending initiatives like HELI's offering of this is an excellent place to go. There are other groups that do work, and my good friend who's on this call, Jen Brown, who's in the Chicago area in Northwestern, there are people who are doing this work. Start looking at the groups that are meeting so that you can get to know the constellation of community members across the country who are doing this work. HELI is perfect for this, and make sure you continue to attend these to meet people who are like-minded that can give you not only opportunities for doing research, but good ideas that you can banter off of. Now, these are also the same people who are extremely busy. Give it to the busy person for you should surely get it done. But there's enough of us around where you don't have to just rely on one individual. And so I want to give hats off to HELI for having this offering. The second is there are now more offerings of minority PI, forgive me for saying that way, because I'll come back to minority serving institutions. Let me say this one first. There are multiple PI mechanisms now, and that is now the trend for many projects, particularly things that are complex like health equity, community-based interventions, and having multiple PIs where you have a senior level PI who has the experience, who is in this space. Some of those PIs are willing to bring you on board. You have to do the work, but they're willing to use their name to assist you to get to that next space. Case in point, there's somebody at South Carolina right now who has me on a grant. Now, look, I'm not a PI. I'm not going to be a PI with them on that, but that person is using someone else to be a co-PI on their project so that they can push the envelope forward, because NIH is going to look to see whether you not only have the experience, but that the team that you have has the experience to get the work done. And bigger grants are requiring multiple PIs so that you can demonstrate that you can collaborate, because in the work that we're doing around health equity and community engagement, it requires collaboration. If you are not at schools that are the big behemoths like Wisconsin or the University of North Carolina at Chapel Hill, or any of these other large Research One institutions. What Research One institutions means, these are these large institutions that get millions and millions of dollars. And then you have emerging research institutions, which are ERIs, or you have minority serving institutions, or MSIs. And often those may be smaller, but they are now getting grant funding as well. And when those are in those situations, if you are at a minority serving institution or you're at an emerging research institution, start looking at people who are at majority institutions to partner and do your research with. Tisha and I, we're here. We're getting ready to connect along with Sarah to do some kind of work. But this is your opportunity to work with larger institutions that may have the resources and the infrastructure, not only to assist, but possibly either lead in one effort and you take the secondary role, or you take the primary role and they offer assistance through their administrative structure to provide services. So those are mechanisms I wanted to mention, and I wanted to mention that what Tisha is experiencing, I've shared this with Sarah, the Federal Demonstration Partnership is an organization that connects institutions with federal funding agencies to improve how we actually do the administration of research. And so Caitlin, or if you guys have the link, thank you so much, Caitlin. This link is to a report that is the Faculty Workload Burden Survey that was done by Sandy Schneider, who's at the University of South Florida. She did this for 3 different cohorts. And so you'll see the data. And let's put up the one figure that I would like to show, if you don't mind, if you can show the one figure. You guys are so rocking. Thanks, Amanda. This figure comes from her report. This is after 3 different surveys that she did with faculty who were FDP members, the institution FDP members, and they sent the surveys to people at their institutions. And I think they're like 20, 30,000 people who completed these surveys. Look at 2018, any one of these. But if you look at 2018, the amount of time taken away from research to do administrative things, to do the things Tisha just mentioned, is almost 50% of her time, of any of these researchers. This is profound, because what you see is in 2005, it was 42.3%, and now it's 44.3%. So it is increasing the amount of administrative time that is spent trying to do the things that are necessary to do the functional part of research. I'm sharing this with you because it means everybody's going through this. This is clearly known, the Federal Demonstration Partnership. You can go to that website and see whether your institution's involved with this, because they should have gotten their own personal report on this. There are efforts to try to address these issues. We have to do a better job of connecting with our research administrators, and Tisha mentioned this as well. Knowing your research administrator and your research administrator having a good relationship with the Office of Sponsored Research becomes your friend. And you should never, ever, 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 ever do a project. I don't even care if you're coming up with an idea without going to your research administrator, ever. Because they will tell you what can and cannot work before you even engage in doing that work. Never, ever, ever do that. And then if you get the grant, you always, always, always have a quick meeting with that research administrator. So your kickoff meeting is not just the team of people, the community partners, or your research team at your institution. You must include your research administrator, because if that person understands what's going on, some of the gap in communication and streamlining the paperwork can happen, so that your community partners, if they're a subrecipient, can actually get that eliminated, the burden eliminated, and they can get paid. I'll stop here, but those are the things that I heard with what Tisha mentioned, Sarah, and I think this is a really important topic. I'm thrilled that you're offering this opportunity for us to share this work.
Well, thank you both so much. As a research administrator, I promise that wasn't a paid endorsement, but I do struggle at times watching so many of my colleagues in health equity research and endeavors, both in my own institution, but also around me, with some of these administrative matters that I know could be prevented. And some of it is in part the preparation, the pre-award piece of it. And we've often struggled with how to incorporate almost business practices as part of being a PI, but I think that data is so critical to understanding. Some of it is a part of the nature of doing research, but when the scholarship is suffering from the delays and then the extension of the potential risk and jeopardy of partners in community already at risk, putting themselves forward to try to be partnership, and then maybe things not going as planned or as anticipated when, again, there's some preventable measures. So thank you. So, yep.
One other quick thing with what you just said, Sarah, I think something else that is important for this audience to understand as well is having an advocate at the leadership level in your department, particularly if you're your chair or a senior investigator, is really important. And the reason I say that is you want that person to go to bat for you to say that your research is extremely important and that the resources that the department has is going to help support that. Why do I say this? Think about it. We now have to submit more grants now to yield an accepted, a fundable product, right? So what it used to be back in the day, where you could basically submit 2 to get 1 successful, you might now have to submit 5 grants to get a successful opportunity. Guess what resources haven't increased? Those same research administrators have to deal with your 5 grants, the 4 that didn't get funded, the 1 that did. Now multiply that across all the faculty in the department that are trying to all get promoted. And that burden, somebody has to fix that, because you can't keep burdening the research administrators and not provide that support. Some of it is that they triage. Some of it is, can you put in a good product, and we're only going to support those products that have been vetted by a review team in the department. That's another way to do it. But for those of you on the call, finding that champion that's going to support your work to get the resources you need to be able to get your grant out the door is going to be important. Thanks for letting me share that, Sarah. I thought it was really important after what you said.
Yeah, absolutely. And Tisha, I want to ask you for any feedback or comments you have at this point.
I just want to say,
see the head just bobbing.
I just feel like Lori's always preaching. So I mean, I fully agree. That's the collection plate, right? I fully agree with that. And, and I just want to reiterate, I think something you said as well, Sarah, about the lack of training once you get funded. And I've been saying this forever. And one day when I actually have time, I would love to pull together people to talk about that, because the business side of research is real. And even as a K awardee, you have a small budget, but to go from a K budget, research budget, to an R01 is very different. And you're dealing with human resources, you're dealing with research resources. I mean, there's so many things that you're doing, and there's no part of our doctoral training where we learn, anything about business practices that are really key to managing a research. I mean, I've heard people say like the R01 is like a small business. And so you have to treat it that way, and you need to have this training to be able to do that. So, I agree with everything that you guys are sharing. And again, for me, this has been a growth in my thinking as well. It's been really helpful to think about things at a broader level, and not kind of feel like all of the pressure is on me to, to produce the work that I'm so passionate about.
Thank you so much. Yeah, and I do believe, here at Wisconsin, we have such a long history in research and a variety of research methodologies and approaches, but community engaged research and research in health equity is relatively new to many of us. And so a lot of the infrastructure is still set up and designed and uses language and draws on kind of transactional orientations that aren't synced right now. They're not optimal. We're getting there. We've got some innovation. And Lori, thank you so much for encouraging people to find those networks of professionals, because just today I was tapping down at Northwestern talking about incentives and participant incentives remotely, and sort of specialized ways they're handling that in a way that has a lot of appeal to me that could be used here. So I'm going to just take a few minutes to switch to some local UW examples or illustrators to sort of add to this collection of conversation. So I'll ask Amanda if she can pull up my first kind of call to action or recognition, just some things I wanted to make sure that we peppered in here. And again, very respectful of the times we're tapped to lend assistance as administrators can occur well before an award is written and submitted, but it also can occur once it's already landed and there's some noise or interruption that might need attention. So prior to awards going in, our center really relies on what we call our MOU template, which is kind of drawn from a contract orientation, but really walks through the 8 or 10 key areas that tend to be sources of conflict if they're not talked about early on for partnered work. So our academic partners need to be thinking about these things, and our community partners need to be thinking about these things. Has to do with thinking about timelines, fiduciary responsibilities, how the transactions will occur, if there's penalties that'll be tied to them not occurring as they're anticipated, data sharing, things like that. Conversations about use of data and acknowledgements, dissemination practices. We use these things to really try to do some of that early prevention problem solving. Have these things been thought about so that we can be thinking as an administrator, when this lands, we've done some preemptive work around that. Lori and the Federal Demonstration Project conversations we've been having recently just reminded me of this 10% de minimis review, which is something our Office of Sponsored Programs here on campus just recently informed me. This is a requirement or an option for community partners or off-campus partners or community agencies not large enough to have their own facilities and administration or F&A rates. There is a 10%, there is an option to reserve 10% of a grant budget that's coming from a federal source for some administrative support and emphasis as part of the implementation. So I'm getting my feet under me. I'm not fluent on that yet, but I'm very curious about, have begun to recognize already how incomplete the familiarity is with this option. And for those in the audience who are coming from a more community perspective, that's something you can be asking about in terms of considering research partnership with academic campuses. Diversity purchasing is kind of a new fun thing for me. I have a colleague that just recently became the diversity purchasing lead here at UW. We have one at our state level. These are folks making sure that purchases of supplies, purchases of what we call swag in research or giveaways. These folks are really looking to see, are we trying to use minority, veteran, or women-owned businesses? And there's arrangements that really encourage that kind of purchasing trail. So another health equity or equity angle, if you will, on some of the ways we're thinking about expending our dollars, even being mindful of that with vendors that we transact with. Next slide, please. Once the award lands, I've recently been reminded by a friend in the senior dean's level of our school about, hey, how are the indirects being funneled towards addressing some of these health equity research administrative gaps, as you will, if you will. And I come back to some of what you mentioned, Dr. Felder, about the inconsistency of direction or guidance you were getting from different colleagues in different offices, especially on big campuses, but even on your smaller campus. Where is the uniform guidance around community engagement and health equity research? We have pockets of that knowledge. What are we doing to make sure that kind of parallel to clinical research with study coordinators who are, regularly accredited and kind of walked through the requirements of their work? Where is that for our community engaged in health equity research? I think the language of research and research transactions is very disparate right now in terms of talking about research partners as contract subrecipients. those are very different dynamics when you move away from the fiduciary exchange for services into something that's more partnered and co-creative. Participant incentives, we probably need to do a whole nother program on, but there are actually ways to get dollars to people to recognize their contributions that don't have to be as painful. In the interest of time, we'll move to the next slide. Diversity purchasing, I'm putting here because it should be something we're thinking about before, during, and after. So community organizations, if we have folks in the audience coming from more that perspective, what is your facilities and administration rate? Are you aware of asking for, advocating for that as part of negotiating a research partnership? We've talked a little bit about finding champions who can help navigate campus resources and expertise. Here in CCHI, we use a Get Involved platform where we're actually soliciting topical expertise and volunteer service opportunities and making sure we take those out with us into community to try to do some platform matching of interests. That MOU, again, I can't say enough about how much that has brought to light different areas that are common tension points in research partnership rollouts, particularly those that are community engaged, community academic partnerships. And then again, diversity purchasing, one of my new interests. So I think I will invite Lori and Tisha to come back on in case they have comments of what I just shared. We're in the sort of 4-minute realm to the top of the hour, so we will have to be succinct.
I put something in the chat about the research administration and uniform guidance. Sometimes it requires a committee to convene to try to create something that'll eventually be the policy in your institution.
Thank you.
I think that's important to consider.
Thank you so much. There's definitely work to do, and I'm in contact with our Office of Sponsored Programs now to kind of clarify a bit about how this happens here locally. So thank you so much for that. And we will definitely be pushing out some of that information on the workload piece too, the burden.
The burden survey.
Yes, thank you.
I was just going to comment on kind of some of the kickback from the F&A costs. I know that is something that is helpful. I'm sure within every institution, there are different policies that govern how much gets trickled down. But I know at least for me, even with the small rate for Ks, still getting a little bit back is very helpful for professional development. Also for using those funds for additional research related things that have come up. So I do think that is really important. And also the diversity purchasing. I'm not as familiar, but I've heard about that and definitely, try to embed that in grant proposals of different people that you can contract with to really try to enhance those relationships locally.
Yes, exactly. Thank you. I'm just, we're at 2-minute point. I think questions in the chat have been well tended to by everybody. I thank you very much. There's more work to do here at UW-Madison and also at my at the institutions that my colleagues represent. I want to thank you both so much for the time today. We are the Collaborative Center for Health Equity at University of Wisconsin. Delighted to have your time today. I want to give thanks to our production partners in place out of our School of Education. They have produced each one of our programs, and Caitlin will make sure on the evaluation that you can get access to those earlier programs that are archived in case there's some utility there. I want to thank our audience so much for their time. We want to hear from you. Our audience has shaped each one of these programs along with our scholars and our alum. So please watch for a survey that will come to your email inbox in short order. And again, appreciate so much your time and stay well. And good luck towards the end of the calendar year and the academic year to everybody.